with low gadolinium enhancement that's not explained by ischemia or other arrhythmogenic causes and the association with sudden cardiac death. In several international conferences and meeting international speakers, mitral annulus disjunction has been uprising as a very important topic nowadays and a cause for sudden cardiac death. I would like to invite Dr. Ahmed Farid to discuss with you any discussions or points regarding this interesting case. And after that, the floor is for Dr. Ahmed Farid to give us the final dessert of the day by offering us the tips and tricks in imaging and the imaging quizzes prepared. So, Dr. Ahmed Farid, please.
Thank you, my dear friend, for this introduction. And also thank you, Dr. Ahmed Mohsen, for this elegant presentation. Actually, the mitral valve prolapse and the mitral annulus junction was for a very long time was dealt as an benign condition. But as we had seen from your very interesting lecture, that it's not benign all the time. And actually, you should have a very high index of suspicious, and you should put all things together. You should not see one finding and take it lightly, like you have seen that the left ventricle is dilated, and you search it for this. And actually, this was what draws my attention very much during the presentation, because if you see undilated left ventricle, you should not take it that lightly, especially with the preserved systolic function. There is something there. You should search for something there. And actually, trying to quantifying the mitral regurgitation in patient with mitral valve prolapse could be very challenging, especially if it is a late systolic jet, like the case you have presented. So there is a lot of challenges in such case. But let me ask you a question. Have you ever encountered to have a mitral annulus disjunction in the absence of mitral valve prolapse?
Thank you so much, my dear friend, Dr. Ahmed, for this very intelligent question. Actually, I didn't. I didn't encounter an isolated mitral annular disjunction
Mhm.
without mitral valve prolapse. I'm not sure if this is reported in the literature or not, but in my practice, I didn't notice this, to be honest.
Mm. Actually, this is very interesting because I found this once in a case and I tried to search, and it was just some case studies about finding a mitral annulus disjunction without the evidence of prolapse. And actually, it runs in the same categorization for the risk for the arrhythmias, as you had said, without the prolapse. But definitely, the mitral regurgitation is not in the issue because there is no mitral regurgitation in such case. But if it is significant, especially if the disjunction distance is more than 1 centimeter or 10 millimeters, should draws your attention to investigate more in such patients, especially if the patient is complaining of palpitation. And actually, a very important part of your lecture is to diagnose mitral valve prolapse. We always
Yes,
encounter errors and more misdiagnosis in the mitral valve prolapse, especially in young females, and just
yes.
rely on the symptoms. So this is very important to diagnose it in the right way.
Yes, some
Can you
operators
illustrate more
find
about that?
yes, some operators find it very hard to write a normal echo report.
Yes,
And he'd like to add some flavor to his report by adding in the conclusion mild mitral valve prolapse.
yes.
When I see this, I am sure that there is no evidence of mitral valve prolapse, and he just writes this for some reason.
Yeah. And actually, I'd like also to highlight there is a term that called bellowing of the mitral valve. The bellowing is
Yes.
the displacement, but less than 2 millimeters in the annulus. So you should be aware of this terminology so as not to misdiagnose the patient and go through a lot of investigations and entitling the patient to have a disease that it's not there.
Yes, it causes unnecessary anxiety.
Exactly, exactly.
Yes.
So you actually answered the second question that came on the screen now by do you think that mitral valve prolapse is overdiagnosed and poorly managed? The answer is definitely yes. And there is a smart question also. Why, Dr. Ahmed Mohsen, did you choose nebivolol in your case as a vasodilator beta blocker and not other beta blockers? Of course, the answer is evident, but I would like to hear it from Dr. Ahmed Mohsen.
Okay, actually, the second option was bisoprolol, and he was a young male patient. And as you know, bisoprolol can result in erectile dysfunction. So I avoided the use of bisoprolol and just used nebivolol. And you can use metoprolol as well, but I avoided bisoprolol uh,
Yes.
because of the erectile dysfunction. And actually, the least beta blocker associated with erectile dysfunction is nebivolol.
If I may
Uh,
add, also the presence of mitral regurgitation would be benefiting from a vasodilator beta blocker, the same like giving ACE inhibitor. Dr. Ahmed Farid, you wanted to add something?
yeah, I would ask you about that because for a long time we have learned that the best beta blockers in mitral valve prolapse is the propranolol, the Indrol. And because of its multimodal affection, like it reduces the anxiety, because sometimes it's called a mitral valve prolapse syndrome, because it comes with a lot of symptoms like the anxiety and low threshold of pain. And the propranolol, especially in such cases, had alleviate a lot of these symptoms like the anxiety and the threshold of the pain, plus reducing the heart rate. Do you have any idea about that or have some concepts about that, Dr. Ahmed?
Yes, yes. Actually, the second reason behind choosing a nebivolol and not choosing Indral or propranolol is we have some form of cardiomyopathy, some form of early cardiomyopathy. So I wanted to choose one of the beta blocker with evidence of benefit in heart failure. As you know, you can choose either bisoprolol, metoprolol, carvedilol, or nebivolol, as well as nebivolol is long acting, so it can be given once daily, unlike propranolol, which should be given every 8 hours. So
Mhm.
the choice was nebivolol, and I think that the pain was an anxiety mainly, and when I reassured him about his case, the pain decreased significantly. So
Mhm.
I preferred to use nebivolol and tritase as well.
Okay.
Thank you,
Okay.
Dr. Ahmed. The final question, Dr. Ahmed Farid already answered. Is there a mitral annular disjunction cases without mitral prolapse with only mitral valve bellowing? Actually, you already said that it's very rare, and you said you already encountered it once. It's still
Yes.
the research is going because this is like a kind of new phenotype that was discovered with the advancement of the imaging techniques. Usually, this phenotype was overlooked previously. No one could actually find it. But now, with the new imaging techniques and the better machines and the MRI integration and everything, mitral annular disjunction will be more and more diagnosed. And maybe in the upcoming years, we can see whether or not there is a phenotype without any mitral valve prolapse or no. So it's
Okay.
my pleasure and honor to introduce my dear friend, Professor Ahmed Farid from Suez Canal University. He will give us the dessert of this highly scientific night about imaging in different scenarios. So please, Dr. Ahmed.
Okay. Thank you, my friend. So can I share the screen? Okay. Okay. Do you see my screen right now?
Yes, Dr. Ahmed, it's clear. Yes.
Okay, so how we will go with this, we want you to be a little bit alert. I will say a question and I will wait until I see some responses from the floor, and then I will see the right answer, say the right answer, and then I will give a small explanation why this is the right answer. Okay, so let's start. This question number one. This is a 40-year-old female with atypical chest pain, referred for echocardiography. What will be your next step in such patients? Reassurance only, CT coronary angiogram, CT coronary dual order geography, or you'll order an electrophysiological study.
So our attendees can vote on the messages, and Dr. Ahmed will
Okay.
open the Q&A section. You can see the votes, and then you can give us the answer. You can keep your slides to the maximum, and downstairs you see Q&A.
I had here the chats, but I
تحت
don't have.
خالص السطر اللي تحت جنب المايك وجنب الفيديو في سطر مكتوب عليه Q&A.
No, هو مش طالع
Okay.
عندي علشان أنا
I
في full
will
screen.
Okay, I will say it to you. Number
Okay,
2,
okay.
the
Yes,
answer.
yes, I get it.
You can see it now.
Okay. So we have here, someone said 2, 2, 1, and CT coronary angiogram, so it's 2. So the most saying it's 2. But why it is 2? What is this sign called? It's called the RAC sign. The RAC sign is retro aortic coronary. If you see this line in here, this is a coronary passing behind the aorta. So this is an abnormal coronary artery or abnormal coronary course, either an abnormal origin of the right coronary going through the left or vice versa. So if you have any doubt about any coronary anomalies, the first test you order is the CT coronary angiogram, which is number 2, which is the right answer, which most of the attendees have answered. So the best test for this patient is the CT coronary angiogram to see if there is any coronary anomalies and to see the course. It is a malignant course or it's a benign course, and this will define how you will approach this patient later on. Okay, so question number 2. What goes with this finding, this Doppler tracing? Is this a severe AS? You can see here that we have a Doppler flow, parabolic flow that crosses the 4 meters per second. Is it a severe aortic stenosis? Yes or no? Okay, this is true, 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 false MR. Okay, so actually not a severe AS. It's an MR signal. So why is that? If you look at the figure on the right side, you will see that the aortic stenosis does not take all the systole. It takes part of the systole, which is the ejection period of the systole. How you could tell this? Because from the closure of the mitral valve until the opening of the next cycle with the mitral valve, you will see the IVRT is still there and the IVCT or contraction time is still out of there. But if you look at the mitral regurgitation signal, it takes the whole systole from the closure of the mitral valve to the opening of the cycle of the mitral valve opening. So if you look at this trace again, let's go back to the trace that we have seen. Okay. This is taking the whole systole. So this is a mitral regurgitation. So there is also some clues that the onset of mitral regurgitation occurs prior to the aortic valve opening, and the mitral regurgitation is longer in duration and more parabolic in shape, like we have seen here. So the next question. We have here a note over the mitral valve leaflets. What you can see here. Is it mitral valve prolapse? Is it SAM? Is it of mitral stenosis? Or is it an aortic regurgitation? SAM, 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 SAM. Yes, that's right. That's the right answer. It's a systolic anterior motion. If you look at this line, this is the anterior mitral valve leaflet during the systole. It should be flat in here until the next opening of the mitral valve. You can see here in the systole where the septum dips during the pull, the anterior mitral valve is getting closer to the septum. So this is a SAM. And if you look up there in the 2D mode, you will see a very hypertrophied septum. So it goes with an HOCM with the systolic anterior motion of the mitral valve. Okay, the next case. If you look at this M mode of the left ventricle, it goes with the left bundle branch block, systolic anterior motion, mitral stenosis, or a constrictive pericarditis? The bundle, left bundle, one. Okay, okay. So most of the answers are right. It's the left bundle branch. So what we see that this amount of left bundle branch block, because there is a special character which is called a beak in the mode. So if you look at this image, you will peak like the parrot beak, exactly, is like dipping into the part of the system. Okay, and it occurs a little bit late in the systole, and also the peak is just after the instruction of the peak R wave on the ECG. Okay, if you look at, but here we don't have ECG. You'll see it's coming just immediately after the peak of the R wave. So one has to tell that this is a left bundle branch block or this is an ischemic. If you look at this echocardiogram, if you look at this, you would see that the paradoxical septal motion is very prominent at the mid and lower septum with what is called the apical sparing, where the apex is contracting nicely. So if it is an ischemic cardiomyopathy, you will see it's a downstream vessel because we are talking here about an LED. So we have no good contraction in the mid and basal septum and also the apex. But in the case of left bundle branch block, you will see here that only the mid and the basal part of the septum is affected. Also, the wall thickness is preserved, so it's not a squat. So this is a short way to differentiate between a left bundle branch block and an ischemic heart disease. So the next question, look at this. Go. This is a 50 years old. Sorry, I can't move this. Just a second. Okay, a 50-year-old male smoker, dyslipidemic, with typical chest pain. SPECT was done. What's your next step if you see this? The upper image are the stress images. The lower images are the resting images. So this patient, you will give him statins only because you didn't find anything abnormal apart from his dyslipidemia. You will give him an anti-anginal therapy and follow up because you found a small perfusion defect. You will refer him for coronary angiography, or you will perform a CT coronary angiography for this patient. Okay. Okay. So we have diversity. We have one say coronary angiography, one say that we perform CT coronary angiography, and one say we have an anti-anginal therapy because it's small perfusion defect. So the hallmark here is to tell something. What is the difference between these two images? You will notice here that there is no significant perfusion defect you have seen, but the LV cavity is much wider and bigger in the stress compared to the rest of the images. So what does this mean? This means that you have a multi-vessel affection, and this is called a balanced ischemia. So you have more than one vessel affection, and this causing a relatively equal perfusion defect. So it appears that there is no defect in the images for the stress, but the LV cavity is getting bigger. So the LV dilatation with the stress was balanced or decreased tracer uptake of all segments. This is called the balanced ischemia. This is a picture of multivessel coronary artery disease. So in such patient, we have a patient, a 50 years old male with typically chest pain and with risk factors, and he have a pictures very suggestive of multivessel coronary artery disease. Your next step will definitely be refer him for coronary angiography, not to perform CT coronary angiography because the yield for this will be low. Next question. So let's look at this. If you look at this movie, what did this entails? Is it a constrictive pericarditis? It is acute pericarditis? It is absent pericardium? Or it's a pericardial cyst? Okay. Someone get something right. Okay. Okay. So what is the abnormal here? We can see that the left ventricle is moving very freely. There is no septal bounce. The LV systolic function is good, but the axis of the heart is a little bit weird, and there is some abnormal shape of the heart itself. It's called the teardrop sign, which goes with the absent pericardium. So it's a teardrop sign. There is an elongation of the atrium, widening of the ventricles, and the axis or the apex is usually deviated from the normal position. So this is an absent pericardium. So the congenital absence of pericardium, it's usually have the following findings in the echocardiography: the displacement. So you fight to get the true apex when you are trying to scan this patient, and it's very difficult. The exaggerated cardiac motion, and there is sometimes like what you have in constrictive pericarditis. Okay, so the next question: this pulmonary valve M mode is most likely associated with which of the following? Endocarditis of the pulmonary valve, infundibular pulmonic stenosis with prior repair of tetralogy of Fallot, primary pulmonary hypertension being considered for therapeutic intervention, or severe pulmonic insufficiency. Okay. Okay, Dr. Ahmed Samhan should get a prize today. Yes. So what is this sign you are seeing here? It's called a floating W sign. It shows which is characteristic of the severe pulmonary hypertension or significant pulmonary hypertension when you put an M mode on the pulmonary valve. And why does this occur? Because of the sudden rise of the rise of the pulmonary artery systolic pressure, making a closure of the pulmonary valve a little bit early. So it gives you this dip sign that you see, what's called the floating W sign, which is characteristic of significant pulmonary hypertension. Question number 8. So you have here a 70 years old male, hypertensive, complained of acute chest pain radiating to the back, and CT was done. So what are you seeing here? Is it a DeBakey 1 aortic dissection? Is it a penetrating aortic ulcer? Is it an atherosclerotic changes in the aorta? Or it's an intramural hematoma? Okay. Okay. Okay, so most of you got it right. It's an intramural hematoma. So what is the differences between the intramural hematoma and the aortic dissection? In the aortic dissection, you will see a true lumen and false lumen, and you should see a site of entry. So you should find a site of entry, and sometimes you may find a site of exit also, but here there is no site of entry. So this is about the intramural hematoma. If you look at here, okay, this is an intramural hematoma. There is some calcifications there, so this is, yes, you have some atherosclerotic changes, but it's definitely an intramural hematoma. Okay, if you look at this M mode, what you could diagnose from this, is this an MS, is this an AS, is this an HOCM, or an aortic regurgitation? Okay. So if someone tells the answer, why we see this is an HOCM? Yes, this is a HOCM, but why we are seeing this? If you look at the M mode for the opening of the aortic valve, classically you would see a box of the aortic valve opening, but you will see here there is a dip or a mid-systolic AV closure, and then the valve opens again and then it closes. Why this happens? Because in the dynamic obstruction during the contraction in patient with HOCM, the first part of the cardiac cycle, or the first half, where you have a very forceful contraction that causes the aortic valve to open. And then then when happen the obstruction. So it closes all of a sudden, and this calls a premature closure of the aortic valve or the mid-systolic aortic valve closure. Then after that, the ventricle starts to release a little bit more ejection of the blood through the aortic valve, and the aortic valve opens again late part of the systole, and then it closes again. So this is a classic HOCM pattern with a mid-systolic AV closure. So trace number 10, if you look at this trace over the mitral valve, is this an AV dissociation? Is it the raised left ventricular end diastolic pressure? Is this a HOCM, or this is a mitral stenosis? AV dissociation. Okay, but look at the ECG above. Okay, if you look at the ECG above, you will have a PQRS, regular heart rate, and you have an E and A waves. So this is not AV dissociation, but you get another finding is right, the diastolic MR. Why we are seeing where we are seeing the MR? At the tip of the QRS complex, this is the start of systole. You can see there is something here. This is at the MR that before the QRS complex, and it goes with the raised LV in the diastolic pressure. It may happen in AV dissociation, but this is not the case here. The case here, this is a sinus rhythm patient, and this is because of the raised in the diastolic pressure, and it caused diastolic MR with every beat. Because in AV dissociation, it does not occur with every beat. Okay, so this is another example of the diastolic MR. In cases of restrictive mitral inflow and diastolic MR, you can see here the MR is occurring before the onset of the QRS complex. So look at this one. This 40-year-old man with atrial fibrillation 48 hours, referred for CT for clearance of the atrial appendage prior to cardioversion. Actually, this was one of our patients that had this during the COVID, where the transesophageal echocardiography was almost contraindicated. So what are the findings here? Is this a clear multi-lobe left atrial appendage? There is a left atrial appendage thrombus, or you have an aneurysmal left atrial appendage? Okay. Any other comments? So we have a right answer. This is a clear multi-loop left atrial appendage. And you should be aware that the left atrial appendage has very multiple and variable patterns of its shape. So you may have the cauliflower, you may have the chicken wing appearance, you may have the flat appearance. So it has different shapes. What we have here is the cauliflower appearance. So you see it's like a cauliflower with multiple pectinate muscles and multiple loops. So this is a clear multi-loop left atrial appendage. So question number 12. So if you look at this M mode, is this of left bundle branch block, systolic anterior motion of mitral valve? Is it mitral stenosis or is constrictive pericarditis? Okay. Dr. Ahmed Samhan is a great winner today. Yes, it's a constrictive pericarditis. Why we are seeing this? If you look here, you see the ECG, and you'll see here a respirometer. And here, this is the posterior wall, and this is the septum. What happened here? Let's see, with the inspiration, you will see a dip in the septum. It's not reflected on the posterior wall. So only the septum is dipping during the inspiration, and it goes up again. And then with the next respiratory cycle, it dips in and going up. So this is a very characteristic of the constrictive pericarditis. Okay, you may have some fallacies or diagnosis for this, like the left bundle branch block or the RV pressure overload, pericardial tamponade. But it's not occurring with this image. Is this a flail anterior mitral valve leaflet? Is that prolapsed anterior mitral valve leaflet? Is this a vegetation? Or this is an annular calcification? Okay, so that's the flail mitral valve leaflet disease. Where it points? If it points toward the left atrium, the tip is pointing towards the left atrium.
I
You
think
call this
your
a flail.
internet
If
connection
it
is
goes
not
to 2
great.
millimeter, and if you have a prolapse, you have displacement more than 2 millimeter, but the tip is still pointing toward the ventricle. And if you have retraction of both leaflets, this is a functional mitral. Okay. Is this a mitral ring? If there is an AC, is a core triatriatum? Is this a commoden ridge? So we have a structure that is splitting the left atrium into two chambers. So it could be one of two things, either a mitral ring or a core triatriatum. This is not a commoden ridge. Okay, so how to differentiate them? The differentiation comes from which level this occur. If it is below the left atrial appendage, so very close to the mitral valve, this is a mitral ring. If it is below the left atrial appendage, then it's a co-triatrium. I think this is a little bit deep into the left atrium, so it goes with a co-triatrium. Okay, this is the last slide. Look at this trace, continuous wave trace. If it goes with a mitral regurgitation, mitral stenosis, coarctation of aorta, or an aortic stenosis. Yes, all of you get this right. This is a coarctation of aorta with the classic. So you will have that the trace is not going to the baseline over the descending thoracic aorta, and the velocity is raised here. It reaches 4, so it is significant obstruction. Thank you all for your participation in this activity, and thank you, Dr. Muhammad, for giving us the opportunity to make this quiz. Thank you all.
Thank you so much, Dr. Ahmed Farid. It was amazing. I enjoyed it so much. Every single question and every single quiz had a learning point behind it. Thank you so much for accepting the invitation tonight, Professor Ahmed Farid and Professor Ahmed Mohsen. Dr. Ahmed Mohsen, do you have any point to discuss with Dr. Ahmed before we conclude?
Thank you so much, my dear friend, Dr. Ahmed Farid. Actually, very challenging quizzes, very fruitful, and very um, educational. I enjoyed a lot, and thank you so much. You focused not only on echocardiography, but you showed us thallium and CT and echocardiography, teaching cases, rare cases, challenging cases. Thank you so much for this amazing collection.
Thank you,
Thank,
thank you, my
thank
friend. This
you.
is really amazing to hear that you enjoyed it.
Thank you so
Yes.
much, all of you.